Good morning and welcome to the December 2020 Levitt Lecture. We have a treat in store for you today. Louis Levitt was born in 1897 and in Denver, Colorado, and he went to medical school at the University of Colorado. He also went to vet school here. And in 1927, he set up his general practice in Denver, where he practiced for 40 years, and upon which he retired in 1967. When he died in 1976, he had bequeathed to the department an endowment, which was intended for the purpose of inviting lecturers and speakers to our campus to instruct us, inspire us, and to organize us around the most important issues of the day in health and medicine. And since that generous endowment, we've had almost 80 Levitt lectures. His gift to us has been immeasurable in value. And I want to once again thank him and his family, as I do at every Levitt lecture, for that generous endowment. The Levitt Lectureship learned of CSTAHR's plan to implement an annual lecture in Greg White's honor. You might have noticed in the flyer that this is the first annual Greg White lecture. This is the Greg White lecture co-sponsored by the Levitt Lectureship, but we thought this was an especially timely occasion in which to focus on health disparities and racism in medicine. This is something that the CSTAHR program has been focused on for the last 10 years. They have been involving students and community members who aim to reduce the effects of bias and racism in medicine on health outcomes. So our feeling is that this was probably the best possible group to decide what will be presented. So we offered to support the Greg White Lectureship, which we will do on an ongoing annual basis. And we're here today for the first Greg White lecture. Greg was one of the community members who served both as community grounding and as faculty for the students in the CSTAHR program. And he was lost to us from colon cancer, which is one of the health conditions which is most serious in its health disparities affecting African American communities. So it's very fitting that our first lecture today will have to do with colon cancer and racism. Before I introduce our speaker, I'd like to introduce us to CSTAHR. Let's hear from CSTAHR about Greg White and his impact on this program and our communities and our medical school.
Greg White.
He was a complex person with lots of layers.
So I think I would describe Greg as someone who was just incredibly committed, really dedicated to working towards health equity and using his own experiences to help inform how we can create a more just healthcare system.
Greg was a very unique kind of guy to me.
Some of the adjectives that I would use to describe him: passionate, unapologetic. He was just overall just this wonderful, genuine human being that I think had a really difficult life, and in my mind found a way to heal through CSTAHR. Hi, I'm Erica Martinez. I am currently a third-year resident at Stanford University.
Hi, I am Bella Mohapatra. I am a family physician that works at Clinica Family Health.
Hi, my name is Mackenzie Garcia. I'm a fourth-year medical student in the MD and PH program at CU.
Hello, my name's Michelle Wheeler, and I'm a founding member of CSTAHR.
I think that CSTAHR really meant a lot to him because it was one of his ways of using all of his experiences with racism and the trauma associated with that to make our community better.
He helped create CSTAHR. He chose to invest in us and chose to teach us because he wanted to make healthcare better for people.
I think he valued most the relationships that he had with the students. He really thought that they were going to change the world in terms of, getting rid of racism in healthcare. He always kept us on track. He would always steer the conversation back to, so what are you going to do? And not just the individual. What are you going to do as a group? What is CSTAHR going to do as a group to end, racism in healthcare?
So this is a letter that I wrote to Greg. It was really just more of a personal reflection for me. I wrote it the night that he died. Dear Greg, I should have written this when I could have read it to you in person, but I missed that chance. So this is the best I can do. Actually, the best I can do is work throughout my life like you did to make the world a better place. I promise to listen to my patients with my whole heart, to consciously evaluate my own biases and the impact that my perceptions have on other people, and to work with others to create the world that you envisioned.
I know I'm going to be a better physician and a better surgeon for my patients because I met Greg. I think that his legacy was that each of us are going to carry a little bit of him to all of our patient encounters, to all of the projects that we're a part of. Speaking on behalf of all students and all current physicians, residents, everyone who has interacted with the CSTAHR community, I feel very confident in anyone who has known him that they are going to continue to work to fight against racism and discrimination in every way, shape, or form.
Thank you very much. It's such a privilege for me to introduce to you Dr. Fola May, who is today's Greg White lecturer. We have had many distinguished Levitt speakers over the course of this lectureship, and she might be one of the most distinguished. Dr. May is the director of a quality improvement program in a laboratory at UCLA, where she works as a gastroenterologist in the division of digestive diseases at UCLA School of Medicine. She's also in the Comprehensive Cancer Center at UCLA, and she's in Kaiser's Center for Health Equity there in Los Angeles. She comes to us with an impeccable pedigree. She graduated cum laude from Yale Medical School, from Yale University, where she did her undergraduate work. After which she went to the University of Cambridge in the UK and studied epidemiology and international health. She then came back to the US and enrolled in and graduated from Harvard Medical School. She subsequently did her internal medicine residency program at Mass General Hospital. And then she moved from the East Coast to the West Coast to UCLA, where she did a GI fellowship. She also earned a PhD in health policy and management at UCLA. So she is an MD, PhD, Master of Philosophy, pedigreed clinician who runs a very productive research lab at UCLA, spanning the range of studies having to do with the basic science of gastroenterologic diseases to population health, to preventive health, to health disparities, implementation science studies. It's quite an impressive portfolio of research that's going on in her portfolio. She's also done quite a bit of global health. She's participated in projects in Costa Rica, Nigeria, South Africa, Uganda, Malawi, Tanzania. For all of that, you might think that Dr. Fola May is an intimidating or somewhat off-putting presence. She is the nicest, most generous-spirited person you would ever hope to meet. She is the very picture of generous, scientific integrity and accomplishment. And it is my distinct pleasure to introduce to you, and I hope you'll join me in welcoming Dr. Fola May as our first annual Greg White Lecturer. Dr. May.
Thank you so much for that wonderful introduction. Good afternoon, everyone. I'm so excited to be here today, and I'm so grateful for the opportunity to speak with you. I'm going to start by just sharing my slides. Fantastic. So as mentioned, my name is Fola May. I'm a health equity and health services researcher at UCLA. This is such an honor to be here today to provide the Levitt Lecture for the Greg White Annual Lectureship. And the title of my talk is Colon Cancer and Black Race, Barriers and Opportunities. I did not have the opportunity to meet Mr. White, but I've heard about his incredible leadership and advocacy. And I know for sure that we are losing way too many people to colon and rectal cancer, especially Black men. So I give this talk today in honor of him. My hope today is to provide an overview of colorectal cancer impact, especially among Black Americans in the United States. I'll also discuss contributors to racial and ethnic disparities in colorectal cancer outcomes. In addition, I'll highlight disparities in colorectal cancer screening and provide examples of interventions that address disparities in colorectal cancer screening. Here are my disclosures. And before I get started, I want to be clear that when I refer to colorectal cancer, I'm referring to the combination of colon and rectal cancer, which we refer to collectively as colorectal cancer. So sometimes I might say colon cancer when I'm referring to both of them, just for ease. We'll start with a bit of an overview of the epidemiology of disease. This infographic shows the estimated number of new cases of colorectal cancer in the United States in the year 2020. I'll admit that even when I was doing my training in internal medicine and early in my course of training of gastroenterology, I did not appreciate the impact of this disease. It is the third most common cancer in both men and women in the United States. In men, it follows just prostate and lung cancer, and in women, it follows just breast and lung cancer. When we examine cancer-related mortality in the United States, colorectal cancer rises to number 2 in etiology in our country. And this is because it's deadly in both men and women, and because it is not gender specific, as we see with breast and prostate cancer. Thus, it actually surpasses overall deaths from breast and prostate cancer. Colorectal cancer originates in polyps in the colon or in the rectum. On the left here, you can see what a normal colon looks like. So as a gastroenterologist, when I'm doing a colonoscopy, this is what a healthy colon will look like. Over time, however, 30 to 50% of us will develop colon or rectal polyps. And these are small overgrowths in the cells of the lining of the colon and rectum. Unfortunately, over time, a small percentage of these can become dysplastic or develop into cancers. And we can't really tell with the naked eye which of these have the most likely potential to progress into cancer. So when we are doing a colonoscopy or a screening procedure, we actually remove all the polyps that we see to prevent any chance that the patient will develop colon or rectal cancer over time. Unfortunately, though, with years and years and years, some of these polyps do progress, and patients will present with rectal bleeding, changes in the form of the stool, new abdominal pain, and late in the disease with weight loss and fatigue. So the essence of colorectal cancer prevention in our country is detecting these polyps and removing them before this happens. These data are from the CSTAHR registry, which is from the National Cancer Institute and the CDC, and they demonstrate a downward trend in the incidence or number of cases of colorectal cancer and in the mortality from colorectal cancer since the late 1980s. So as you can see here, at around the mid to late 1980s, we have an impressive decline in the incidence in men, the incidence in women, and also deaths in men and women, which is great news. And we actually attribute a lot of this success to the introduction of colonoscopy and screening in the United States. However, to date, there remain stark differences in colorectal cancer outcomes and incidence by race and ethnicity. So, for example, here we are looking at data, national data, that looks at incidence of colorectal cancer from 2012 to 2016. And when I use the term race ethnicity from now on, what I'm going to be referring to is non-Hispanic whites, non-Hispanic Blacks, Latinos or Hispanics as their own category, and then Asian Pacific Islanders as a category, and then American Indians, which are combined with Alaskan Natives in these data. As you can see here, as represented by the light teal bars, African Americans have higher incidence of colorectal cancer, and that's when you look at sexes combined, when you look at men alone, or when you look at women. The incidence is actually then followed by American Indians or Alaska Natives, that's the gray bar here, and then non-Hispanic whites, Latinos, and then Asian Pacific Islanders. So very, very big differences. And we usually quantify this by saying that African Americans have a 20% higher incidence of colorectal cancer compared to whites in the United States. Mortality also varies by race and ethnicity, and Blacks have the highest mortality from colorectal cancer currently in the United States. Their mortality, as represented here in the light teal bars, is about 40% higher than mortality in whites, again followed by American Indians, white Americans, Latinos or Hispanic Americans, and Asian Pacific Islanders with having the lowest rates of mortality. And while today we will talk about the impact of colorectal cancer on all racial and ethnic groups, we will focus largely on African American or Black Americans. And this because they are the group that is most disproportionately impacted by this disease, unfortunately. The good news is that overall, whether you look at males or females, the overall rates of death from colorectal cancer have improved over time. And again, you can see that since the early 1980s, the line is down in everyone, but importantly down in Black men and Black females. But over time, we continue to see this difference when we look at Black Americans compared to white Americans. There are also data that Blacks tend to present with late-stage disease. Now, why is that important? That's important because if a patient presents to me with stage 1 colon cancer, I'm actually able to tell them that their chances of 5-year survival are 90% or greater. However, when a patient presents with late stage or stage 4 colon cancer, their survival drops to 15%. So the earlier we find this disease, the more treatment options there are, the more likely that patients will survive this disease. And that's why much of our focus is not only on preventing colorectal cancer, but detecting it as early as possible where we have the most treatment options. Across the board, regardless of stage, Black Americans have lower 5-year survival than white Americans, as shown here. And collectively, only 58% of Black Americans with colorectal cancer will survive 5 years, and that's compared to 65% of white Americans. The other major change that we've been seeing recently in the epidemiology of colorectal cancer is the age of diagnosis. And many of you may have heard in the media or even in research that we're seeing a higher rate of colorectal cancer in younger adults. 10, 15 years ago, we really thought of colorectal cancer as a disease that impacts primarily older adults or middle to older age adults. So it was a disease that impacted when you were 50 or older. But what we have seen since the 1990s is about a 2% increase in the incidence in colorectal cancer in adults under age 50. So as you can see in the graphs here, when we look at individuals that are age 0 to 49, we have a slow rise in men and women in the incidence of colorectal cancer. So this is the group that we call early onset or young onset colorectal cancer. That's very different than our population age over 65, where the rates have dropped over time in recent years. And again, this is because this is the population here and here that we're screening most effectively. Now, I want to point your attention to the y-axis on these graphs to emphasize that this is still primarily a disease of older adults. The y-axis here is representing the rate of colorectal cancers per 100,000 people, and as you can see here is quite large for the age group over 65, ranging from 0 to 450 per 100,000. And although these graphs are side by side, this range is much narrower for adults aged 0 to 49. So in reality, this uptick that we're seeing in young adults does not in any way compare to the level or grade of disease that we see in older adults. But because these are young individuals that are often contributing to society, often childbearing age, each of these cases is especially devastating. And there has been a lot more attention in public health to understand why this is happening and to develop ways to prevent these cases in younger adults. The burden of early onset or young onset colorectal cancer also falls on Blacks and Native Americans or American Indians. So the rates of young onset colorectal cancer are up in all of these groups. The line here for American Indians is dashed because that's a smaller group and these estimates are not quite exact, but this is a group that we're paying a lot of attention to because even early onset and older adults as well, we're seeing quite a rise. Black Americans, which we've already emphasized, have had early onset and have actually been the highest group for early onset colorectal cancer. And I do want to point out that this is not just a problem of ethnic and racial minorities. Early onset colorectal cancer is affecting white Americans as well. This blue line here is white Americans, and they're having the steepest increase in early onset colorectal cancer over time. And this increase is actually largely driven by white males who are being diagnosed with rectal cancers. So that is a group that, in addition, we're seeing disparate outcomes, and there's been a lot of focus on increased attention to symptoms and to screening. So rather than just point out these differences by race and ethnicity, I think it's really important to spend some time talking about the causes or the reasons for these disparities that we have seen in this country. There are many different factors that contribute to disparities in colorectal cancer. And rather than biologic or genetic differences that are often blamed, we think that the major contributors are environmental, social, and healthcare related factors. So 10 to 20 years ago, we would say there must be biologic or genetic differences between Blacks and whites that are driving the differences in colorectal cancer incidence and mortality. But what we're learning with more and more research that we're doing, genetics are a very small explanation of the differences that we're seeing by race. And in fact, it's more likely differences in the communities that we live in, income, employment, access to health services, and the things that we ingest, tobacco use, alcohol, our diet, how active we are, that are probably playing a bigger role in disparities than genetics. So we like to think of all of these root causes of disparities by race and ethnicity as differences in social determinants of health. Social determinants of health are the context in which we live our daily lives. The analogy that I like to use, and that's used commonly in public health, is that of a river, where the upstream flow or currents of the river are going to impact the downstream currents of the river and activity of the river. So when we use this analogy in healthcare, the upstream determinants of health are the macro social and structural influences on health and healthcare systems. They include governmental policies and the social, physical, economic, and environmental factors that determine all of our health. The midstream determinants are a result of these upstream determinants, and they mediate the impact of the upstream determinants of health on downstream health outcomes. And the downstream health outcomes are the health-related endpoints that we see in our clinics and in our hospitals. These are things like heart disease, obesity, cancer like colorectal cancer, and most recently COVID-19, which we think is the downstream effect of all of these upstream and midstream determinants of health. So to give it a more rigid or more illustrative example of how adverse determinants of health can lead to disparities in colorectal cancer, I have one just outlined here, and we can look at the upstream factor of structural racism, for example. And we refer to structural racism as racial inequities that we see as a product of institutional, historical, cultural, or even interpersonal practices within society that put one social group at a disadvantage or at a position more likely to succeed compared to other social groups. So structural racism is an upstream factor that leads to health disparities through more downstream or midstream factors. So for example, structural racism in this country has led to how we develop our cities and our housing and urban development. It has also led to how we organize our neighborhoods, whether there are parks in our neighborhoods. These things lead to whether or not you live in a food desert, whether or not you're exposed to environmental toxins or safe environments to be outdoors and physically active, which of course can lead to poor diet, intake of processed foods, which we know are related to cancer, and also low activity levels. Over time, individuals that live in these environments have higher rates of obesity, type 2 diabetes, and even changes in the microbiome, which we think are linked to colorectal cancer. And further downstream, we have the downstream health outcome of high colorectal cancer incidence and mortality in underserved groups. So where you live and where you were born, where you work, in many cases will impact your likelihood of getting a disease and dying from a disease. And that's the concept of adverse social determinants of health. So for those of us who've worked in the field of health equity and health disparities and who have been measuring the impact of race on health outcomes for years, we begin to wonder, are we really measuring race when we do the work that we do? Are we measuring racism? Which is a social, because race is a social or power construct that is developed by society and culture, whereas racism is more about our behaviors towards each other in health and in the health system. And this distinction is critical because if we can acknowledge the problem as racism, then we can identify mechanisms by which racism impacts health and health care, and we can actually design, develop, and disseminate interventions that interrupt these mechanisms. So if we identify that it's bias or exclusion, disinvestments in certain racial or ethnic groups, access to care, we can actually target those things, and in doing that, we will actually disrupt some of the disparities that we see. So I think now we'll actually move on to specifically talking about colorectal cancer screening disparities, and that's an area that I've specifically spent a lot of my time in. And we know that all the disparities or inequities that we see in healthcare occur across the entire cancer care continuum. So whether you're talking about risk factors for disease, prevention, diagnosis, treatment, or survivorship, we see these disparities. Now, I happen to work more in the areas of prevention and diagnosis. So how do we prevent cancers from impacting people in the first place, and how do we diagnose them early enough to have impact? But I have colleagues in other areas that work in these other parts of the care continuum to try to understand why these disparities exist, and again, how we can address them. So when we talk about colorectal cancer screening, it's important to note that we know that screening is effective. Screening allows us to detect and remove the colon polyps that I showed you earlier before they become cancer. And screening tests also detect colon cancers early before they cause symptoms. We have several different ways to screen for colorectal cancer, and this is one of the biggest benefits of colorectal cancer screening. There isn't just one test. There are many tests. So when I'm in my clinic consulting with patients about getting screened, if they're not so excited about one particular test, we can actually talk about the other options that are available to them. And those include high sensitivity fecal occult blood testing, as is illustrated here, the fecal immunoccult test, which is the FIT test. We also have one more stool-based test, which is called the FIT DNA or Cologuard test. And then we also have direct visualization techniques. Those include a CT, a colonography, which is much like getting a CAT scan, except for you have to take the prep before, a flexible sigmoidoscopy, and also colonoscopy. And these are both endoscopic exams that allow us to visually examine the lining of the colon. The two new kids on the block that are currently under investigation to understand what populations will benefit from the most are serology and capsule. Serology is the concept that we could take a blood test and look for markers for early signs of colon cancer. And right now it's approved for certain populations and many studies underway to refine these tests to make them more available and better performing. Capsule is the concept that you could swallow something that looks like a pill that has cameras on it, and while it's traveling down your GI tract to your colon, it will take thousands of pictures of your colon to look for polyps. If those polyps are found, we can perform a colonoscopy to take those out. Again, very new and only used for certain populations, but likely will be refined with time. Right now, the two first-tier screening modalities are the colonoscopy and the fecal immunochemical test, or the FIT test. And those are the two that we recommend overall. What we've learned, however, is that we're most effective when we give patients options. So most of us in primary care and in gastroenterology, when we talk about screening, it's important for us to offer colonoscopy, but also talk about some of these stool-based strategies that some patients, especially ethnic and racial minorities, might be more willing to complete. Screening has been extremely successful and impactful in the United States. And I love this study that was done by Ann Zauber and her group. She's a renowned epidemiologist in our field. And she tried to quantify the factors that have led to the reduction in colorectal cancer mortality in the United States over time. So as you can see here, we looked at data from 1975 to 2005, and we've had an overall reduction in US mortality from colorectal cancer. And that what they were able to quantify was that that screening itself, which is this orange bar here, actually accounts for about 40% of the mortality reduction in colorectal cancer between 1975 and 2000, which is huge because it's more data and support that screening has had an impact and a reason for us to focus in public health and in medicine on screening as many people as we can. Nonetheless, we are not very good at this country in getting people screened. And currently, only about 2/3 of the US population participates in screening. And they are represented here by this dashed blue line. So about 67% of adults actually get screened. This is much lower than the national benchmark. Our goal, which was set by the National Colorectal Roundtable and other groups, is to screen at least 80%, so this line here, of the population for colorectal cancer, and as a whole we are far below that. And then as you can see here, there are differences by race and ethnicity. So white Americans have a screening rate of about 70.4% in the United States, still below the benchmark, but the highest screened group. Black Americans have a screening rate of about 66.4%. And we think that certainly because Black Americans are more likely to have colorectal cancer in the first place, this lower screening rate puts them at a disadvantage. But what I will say is that we've made great strides, in this group over time, and that Black Americans used to have rates that were far lower than white Americans, and we've had some improvements. Now, the groups that a lot of us have had increased focus on recently are our Latino, our Hispanic population in the United States with a screening rate in the 50s. And as I mentioned earlier, our American Indian population, which has low screening rates and higher incidence in mortality. Asian Americans, in addition, I'll point out, have rates that are lower than white Americans as well. So a lot of work to do to improve screening for the overall US population, but then especially among racial and ethnic minorities. On top of that, we have the constant challenge of changing screening guidelines. So right now, as of today, our screening guidelines that are set by the United States Preventive Service Task Force recommend that all insurers cover screening for individuals who are age 50 to 75. However, the USPSTF announced in October that they are planning to make a final recommendation that we reduce the age to initiate screening to age 45. And right now it's in a draft form, but we're pretty certain that this will be a final recommendation sometime in 2021, which will be fantastic because it's acknowledging that there's a changing epidemiology of the disease and that colorectal cancer is impacting more young adults. However, it will be challenging. People have made calculations, and overnight, if this is to go into a final recommendation, there will be an additional 21 million Americans who need to be screened for colorectal cancer. And given that we are not doing so great right now, even with colorectal cancer screening across the board, this is going to be very challenging for us to get up to 80% now when we reduce the screening age and include individuals that are 45 to 49 years old. We've discussed the epidemiology of colorectal cancer and contributors to the disparities, and I want to spend the rest of my time talking about solutions, so things that we can do in medicine and in public health to reduce disparities that we see, specifically in colorectal cancer screening, because as we have seen, that has a huge impact on incidence and mortality. When we have information about the epidemiology of disease, we can understand then, as a second step, what the mechanisms are for disparities or differences by race and ethnicity. And then we can go on to develop evidence-based solutions. And much of the work that we do at the UCLA Kaiser Permanente Center for Health Equity is to try to understand how we can move forward that information about epidemiology and mechanisms to solutions. We do research across multiple settings, including UCLA Health, which is mostly a middle to high income patient population, the VA, which is located less than a mile from UCLA Health and services veterans, and also many of our projects are focused in federally qualified health centers, and these are primary care centers that are funded by the government to provide primary care and preventive services to to people in the United States who are low income, uninsured, and underinsured. And I think one of the most exciting things about the work we do is that we're able to work with all of these different populations. In our work, we first have to understand the barriers to screening in the underserved so that we can then address solutions or interventions to address these disparities. And I like to think of barriers as occurring on 4 levels. That would be the patient level, the provider level, the health system level, and the policy level. And on this slide, we'll talk about what some of those factors are. We'll start with the patient level factors. So there are many things that we have learned in research in the literature related to patients that are impacting their likelihood to participate in colorectal cancer screening. So for example, we know that in many cases, sometimes patients just aren't aware of the benefits of screening. Sometimes there are beliefs or cultural factors that impact their likelihood to participate in screening. We know that health literacy and especially language can be a factor, especially in our Latino and Asian American communities. If language and health information is only provided in the English language, then oftentimes the information just doesn't reach patients about the benefits of screening. Beyond that, though, we know that there's fear of the procedure, especially in speaking about colonoscopy. There's a lot of hesitance because it's perceived as an invasive procedure. You need to come into a hospital, you need to be put to sleep or at least receive conscious sedation. And there's a lot of hesitancy about that. And closely tied into that is mistrust, because if we are helping provide care for populations that have mistrust for the healthcare system, there is a lot of hesitancy about getting an invasive procedure like colonoscopy. In addition to that, there are competing demands. Colonoscopy, for example, requires you to take a day off of work, do a prep the day before. For the procedure itself, you need to have an escort, which is a family member or friend, accompany you to the procedure and drive you home. These are all challenges for people and who work in certain demographics. Not all of us can take a weekday off from work. Not all of us can find a family friend or escort to take us home for the procedure. So those weigh in as well as competing demands or logistical challenges. It's important, though, to note that all of the barriers are not on the patient level. And I think often we focus too much on the patient level. There are things that we are doing wrong as providers that are also contributing to this problem. So there have been studies that have shown that providers in primary care and in gastroenterology don't answer questions right when they're asked about the screening guidelines. Some providers have misconceptions about the benefits for screening or practice in a way that screening isn't, or prevention in general, isn't a priority. Lack of recommendation is a big factor. We know from many studies that whether or not a provider recommends screening is critical for patients, but often in our clinical visits, we do not recommend screening, and that unfortunately happens more for ethnic and racial minorities. In addition, there are time constraints. We all are struggling with the 15-minute appointment. How do you deal with active medical problems and, in addition, address preventive services like screening in that period of time? At the health system level, whether or not you have colonoscopy capacity, access to screening, whether or not there are quality systems in place at the health system or reminder systems for providers to help them and nudge them when patients are overdue for screening, have all been shown in the literature to play a role. And then I think harder for us to address are the policy level factors. And by that I mean things like the USPSTF guidelines, whether or not those are in place for screening and for prevention, whether or not they change. We also know that insurance policy is important and coverage policy. If insurers are not covering screening, it's much less likely that ethnic and racial minorities will be able to participate. And in addition, if the coverage isn't completely free and there's a copay, we know that ethnic and racial or low income individuals are less likely to participate in the service. So these are all policy level factors that, as researchers and physicians, providers, community workers, we don't always have the opportunity to adjust or to influence, but many of us are working at the state level and at the national level to try to make sure that we get into the ear of our politicians to make sure that there are beneficial policies to get people screened and to get them their preventive services. I want to spend a little bit more time talking about mistrust, because I think specifically in the Black or African American community, this is a factor that is often brought up in the literature and in our discussions. I think it's important to break down this concept of mistrust and why we are seeing it in health and healthcare and related to colorectal cancer. There was a qualitative study that was performed and with the aim to understand perceptions of the healthcare system and of medical research. And researchers found that when Black Americans were asked to explain a hesitancy or reason for not enrolling in research studies, they often felt that they did not want to participate because they felt that these studies involved experimentation. They felt like rats or guinea pigs that were being experimented on, or that they were being treated like test tubes. So this just highlights the large sense of mistrust of the healthcare system that is a primary barrier for participation in medical research and also in medical care among Black adults. And in this study, they took a second dive to try to understand why this mistrust exists and the main reasons for distrust. Blacks stated that specifically historical exploitation. So we talk about the impact of the Tuskegee studies that occurred and that violated Black bodies, But in addition, there have been other examples of exploitation and experimentation done in an unjust way to Black Americans over the history of time in this country since Blacks were first brought to this country as slaves. And because of that, that has inbreeded in the Black community a sense of what I call rightful mistrust of the healthcare system. In addition, there have been instances of unethical medical care. We know that there are already inequities in access to care and very little attention to these inequities. So why would you trust a system that's not trying to help you? And then you'll hear personal accounts, as documented in this study and others, that when Blacks actually do present for care, they feel that they are treated with disrespect and discrimination. I actually saw a study that looked at this, and it's not just a feeling. They looked at physicians who are providing care and delivering news to white patients and Black patients. And when the physicians were delivering the news to the white patients, they typically came into the room, pulled up a chair, sat down. They even spent more time talking to the patients about the clinical results or the implications. With Black patients, less time was spent in the room. Physicians often kept themselves standing during these conversations, and often, unfortunately, even at the doorway to present unfortunate news to these patients and their families. That is an incredible amount of disrespect. And as you can imagine, if you've had that experience with the healthcare system, that level of discrimination, it's very hard to bring yourself back unless you absolutely need care. So in this study and others, Blacks have perceived that there is just no benefit for Blacks to participate in healthcare or in health research unless they absolutely have to. And again, due to these personal experience and these unnecessary exposures. So mistrust is real, but I think it's rightful, and it's because of things that we actually have done in our health system, unfortunately, to Blacks, not just Blacks, but to underserved and underrepresented groups. In the same study, they actually looked at themes for barriers to screening and colorectal cancer. So this is bringing this more proximally to the problem that we're talking today about, which is colorectal cancer screening. And many studies have shown that there are themes that are consistent with mistrust, distrust, and just a lack of understanding of why you would present for medical service when you don't even have symptoms and you don't even know why it's important. We know that Black patients have this high sense of mistrust. We know that there's skepticism about motives. Why do you want to put an instrument in my rectum and look for polyps? I'm not understanding. Are you going to violate me during that time while I'm put asleep? There's concerns about competency of the providers that are doing the procedures. Worry about whether they'll be treated fairly, whether that's in the clinic or whether that's under sedation. Again, this fear of experimentation and the invasiveness of the procedure. And I think particularly among Black men, we see all of these things, but one of the things that has unfortunately also been a big barrier to receiving colonoscopy and colorectal cancer care is the unfortunate negative feeling among many Black men about homosexuality. And I personally have witnessed this in my clinic where I've had Black male patients, unfortunately, as a result of how we as a society have dealt with sexual orientation, and especially in the Black community, how that has been stigmatized. I've had patients ask me, if I have you do this procedure that allows you to put an instrument into my anus or into my rectum, does that say something about my sexuality? Which unfortunately is ridiculous, but it is clearly a barrier that is preventing some Black men from getting screened in a timely manner. On the provider level, as I mentioned, there are many barriers, and I just want to highlight one of them before we move on. And this has to do with recommendation for screening. And as I mentioned earlier, whether or not a provider recommends screening is extremely important. And for the providers that are listening to this, the number one thing you can do to help address disparities in colorectal cancer is make sure that you recommend screening to all of your patients, regardless of race and ethnicity. We did a study, actually, this is one of the first studies that I did in this area of research, where we looked at provider recommendation for screening, and we found that Black Americans were more likely to report that the number one reason why they had not participated in colorectal cancer screening was because no provider told them the importance of the study. So in addition to recognizing the need for this within the own medical community, we need to make sure that we translate that forward to our patients, especially our Black patients. Screening interventions are designed to address exactly the barriers that we just discussed a few slides ago. And again, I like to break these up as provider-focused, patient-focused, healthcare system focus, and policy focus. So there have been many things that have been done in the literature, that have been researched, that have shown to be effective, that are directed towards patients to improve screening utilization. A lot of these are focused around education or direct outreach. Many of you may have seen in clinic settings or even via telephone or mailed outreach, sending information to patients about the importance of screening. There's also been use of reminders in the clinic setting, and these can be printed, telephoned, mailed, even through electronic patient portals, reminding patients when they're due for screening. Of course, media has been used. And the things that are a little bit more innovative that have been effective in some settings are incentives. So actually giving patients incentives to be screened, whether that's financial or other, and patient navigation. And this is the concept that if you have a nurse or provider walk patients through the screening process, they're more likely to complete the screening test. Provider-director interventions are less common, and this is unfortunate because I think there could be a lot more work in this area. But with provider-level interventions, we have seen that if we directly outreach to providers, we can have the same impact. We can have providers be more likely to recommend screening. Providers have also received print media, and incentives have been effective in some cases, although there are data on both sides of that, some showing that incentives to providers to recommend screening is effective, and others showing that it's not. And the other thing I'll highlight is assessment and feedback. So interestingly, there are studies that show that just providing providers with reports of their colorectal cancer screening rates and showing them how low they are can motivate them to recommend screening more often. System-directed approaches include reminder systems through the EHR, changes in clinical workflow. Many institutions have started population health management groups or committees to address colorectal cancer screening efficiency. Again, using patient navigators at the health system level and introducing into the EHR prompts or nudges to increase provider recommendation or ordering of screening tests. The policy-directed interventions are tough because not all of us are in positions where we can inform policy, but we can lobby, we can advocate, we can impress on our politicians the importance of this work, and many of us have done that, whether it's through impressing on our politicians the importance of insurance mandates, support for federally qualified health centers, coverage for preventive services as we currently have in the Affordable Care Act, in which we hope continues, or eliminating cost barriers. And we've had some major movements forwards in eliminating cost barriers for things like colonoscopy, which I think has gotten more patients interested in participating. I want to highlight a few examples of interventions that are in the literature that have been effective in increasing colorectal cancer screening rates. This was a study that included low-income Blacks and Latinos that were between the age of 50 to 75 in one large medical center. It's a randomized control trial in which half of the group received telephone individualized education about colorectal cancer screening. They had dual language, they had bilingual navigators to talk to patients in Spanish or English as appropriate. And they compared screening uptake to individuals who did not receive the intervention, so were in the usual care arm. And 6 months later, looked at who completed colonoscopy. And as you can see here, the navigation group, so this is the group that got the telephone delivered counseling, was more likely, significantly more likely, to participate in colonoscopy. We've also had a lot of success in reaching patients outside of the healthcare system. So not all patients are going to be in the healthcare system or seeing their providers frequently. And I really like this study that comes out of NYU, where they did a patient-level intervention in barbershops. They said, where are African Americans? And they're often in places of worship and barbershops, and they wanted to target Black men who were disproportionately being impacted by hypertension and colorectal cancer. So in this 3-arm study, one group of patients received navigation and counseling about colon cancer, One group received interviewing and counseling about hypertension, and a third group received both the hypertension and the colorectal cancer counseling. And as you can see, the patients that got navigations about colorectal cancer in the blue bar were more likely to participate in screening at 6 months. And interestingly, equally interestingly is that the group that got both interventions, so they gave these patients both hypertension and colon cancer counseling, were also likely to participate in colonoscopy or in screening in general at 6 months. And I love this study because if you look at the number 1 and 2 killers of African Americans, it's cardiovascular disease and cancer. So they in one study took on both of these problems. Another example is mailed FIT. So this is the concept that we can mail patients a FIT test, which is a fecal immunochemical test, one of the stool-based screening tests, and that they can complete it at home and mail it back to the health center. It does not require a visit. And in this safety net system study that was performed at UCSF, they included over 10,000 Black and Latino patients. And they were able to show that when the group that got the intervention was much more likely to complete complete a FIT test for screening. The intervention included a mailed postcard followed by a telephone call. The patients were then sent a FIT kit in the mail. And if they did not return the FIT kit within 2 weeks, they received a reminder call. The arm 2 was just the usual care arm. And as you can see here, the uptake in screening was 60% in the intervention group. So when we mail people a FIT kit at home, we reduce their need to come into the health system, and they're likely to participate in screening. And this is not shabby. I know it's not 80% or 100%, but given how hard it is to screen people for colon cancer, this is a major triumph in our field to see 60% of patients participate in screening. So what we do at the Kaiser Permanente Center for Health Equity is we look at all of the data that are out in the literature, and we try to come up with the best implementation strategies so that we can carry forward this research to federally qualified health centers that are in the Los Angeles area. And we have learned through the literature and through the work of others that interventions are best when they're multi-level, multi-component. So again, addressing patients, providers, systems, and policy where possible. It's effective when interventions are culturally tailored to African Americans or to the group that you're trying to target. And it's helpful and important to work in community settings. I sit at UCLA Health, which is on the west side of LA, which is a rather affluent area. I'm not going to impact health disparities by sitting here in this ivory tower. We need to go into the community where Black and Brown patients live if we want to impact colorectal cancer screening rates. And we need to engage with patients and stakeholders in those settings. LA County is an incredible place to do this work. It is the most diverse county in the United States. We always like to say that if LA County were a state, it'd be the largest state by population in the United States. We are also a majority minority county. So 74% of residents in Los Angeles County identify as being an ethnic or racial minority. We have a large number of Asian immigrants and 225 languages that are spoken. So this is an incredible place to be doing work in health equity and health disparities. Specifically looking at federally qualified health centers, which again provide preventive and primary care services to low-income, uninsured, and underinsured individuals. We have 49 alone in the county of Los Angeles. There are some states that don't have more than 3 or 4 FQHCs, so we have quite a large landscape, and they are distributed around 320 sites. So again, I sit here on the west side of LA, right on the coast. And as you can see, these dots that represent the FQHCs, they're mostly east, north, south of me. So a lot of the work we do is partnering with these FQHCs in areas where we have larger numbers of Latinos and African Americans to administer these programs to help improve their colorectal cancer screening rates. FQHCs have historically struggled with colorectal cancer screening. These are data from the UDS, which is national data, showing that even up into 2019, only 45.6% of patients in federally qualified health centers have received colorectal cancer screening. And when we looked at California data, 40% of federally qualified health centers in California say that less than 40 that say that 40% or less of their patients are up to date with screening. So a lot of work to be done nationally and in our state. The work that we do when we partner with FQHCs is we develop advisory committees. We work with the clinic to do clinic engagement, and actually we just sit in the clinic. We place team members in the clinic just to monitor how they deliver care and how they deliver colorectal cancer screening services. And the other thing that we do is we do key informant interviews with staffs at the clinic. And that helps inform the interventions, again, multi-level interventions that we're going to introduce to the clinic to increase colorectal cancer screening participation among the patients. For example, the Northeast Valley Health Corporation is one of the largest FQHCs in the nation, and it happens to be here in Los Angeles. They have 15 health centers that are around our county, and they provide care to 290,000 individuals or healthcare visits a year. It's 95% Black and Latino, and they screen primarily with the FIT, which is the stool-based screening test. When we started working with this clinic in 2017, their screening rates were around 49 to 51%. And we partnered with them in two efforts, addressing the entire colorectal cancer care, or screening, I should say, continuum. And our first grant was to help them improve their overall screening rate above 51%. And then we had an additional grant with them that was specifically focusing on getting colonoscopies for patients who have abnormal screening. So this is just a reminder that that FIT test is a two-step screening process. And if it's abnormal, these patients still need a colonoscopy. So we work with the FQHCs, especially Northeast Valley, to try to understand how we can get more patients with an abnormal FIT result in to see a gastroenterologist for the colonoscopy as indicated. We've tried multiple interventions at Northeast Valley, and these are just examples of some of them. Again, emphasizing that the interventions are at the patient level, but also the provider and the system. For patients, we have created these wordless instructions. A lot of the patients were just completing the FIT kit incorrectly. And we worked with some colleagues at UCSF who had done something similar in their FQHCs, and we made a set of instructions that were picture only, so that patients could not overfill the kit or do it incorrectly. Because the last thing you want is a patient to participate in screening and then you can't even get valid results from the test. We also, at the provider level, have started feedback reports to help providers know how they as an individual are performing, and many system level workflow changes. So for example, we've changed the EHR so they better document when a FIT test is administered. We've standardized the language around recommending a FIT that MAs and providers that can use. And we've made the FIT kits more available. We put them in the lab. We put them in the front of the clinic so that people who don't get it from their provider can get them at other steps during the clinical interaction. Now, of course, 2020 hit and things changed for many of these projects, especially in our federally qualified health centers. And COVID-19 has largely impacted colorectal cancer screening in the United States. There are national data that say, for example, that utilization of colonoscopy dropped by 80 to 90% in most health centers. So a lot of our current research priorities are assessing how COVID-19 has impacted clinical processes and screening rates. And we've tried to establish safe processes and efficient ways for patients to continue screening, even though we are facing a horrific COVID-19 pandemic. So we've started mailing the kits more in the FQHCs. We've also started doing more telephone and mailed outreach to educate about screening and to talk patients through the screening process. And I think in addition to all this, we're also getting geared up for what we anticipate will be new guidelines. And suddenly these FQHCs will have to screen everyone who's 45 to 49, in addition to those who are 50 to 75. So we're thinking forward to ways that we can help them do that so that their screening rates don't plummet. We focused a lot on colorectal cancer today as an example of health inequities and health disparities, but I want to spend the last couple minutes talking about health equity as a national focus. We will not be able to make strides in colorectal cancer disparities or in any disparities in any health outcome unless we as a nation pay more attention to this problem. And I've outlined here some of the things that we all think need to happen for us to really embrace this problem and to address it moving forward. For example, we need to collect more accurate data on race, ethnicity, and social determinants of health. When COVID-19 hit, we didn't even at first recognize that there were disparities by race and ethnicity because many of the hospitals didn't keep data on whether patients were Black, white, Latino, Asian. And it wasn't until later that we noticed those trends. We need to do better. We need to mandate that we keep these data and that we keep track of not only race and ethnicity, but also work and living environments because we know those impact health. There's a need for increased federal support for research and disparities. And I had the honor this year of participating in a congressional briefing where we highlighted to Congress the importance of health inequities and health disparities and lobbied for increased funding to the National Institutes of Health, or NIH, to increase funding for research in these areas. And we're hopeful that they will do that. We need to increase representation of underrepresented minorities, or URMs, in medicine and research. Of course, this research can be done by members who are not ethnic or racial minorities, but we know that when you put more ethnic and racial minorities in science and in healthcare, they're more attuned to these problems and more likely to dedicate their careers to solving them. In addition, we need more equity and patient participation in cohort studies and clinical trials. This has been highlighted in a lot of the work that's been done around the COVID vaccine. If you don't have Black and brown patients in your trials, it's a disservice. And that's not just about the COVID-19 vaccine, that's in any area of medical research. So there's a big push for that. In addition to increasing community academic partnerships to address healthcare disparities. Many times, community health centers, federally qualified health centers don't have the resources to do disparities research. They are so busy in dealing with the day-to-day workflow of providing clinical care. So the academic community partnership is perfect where people like me who are researchers can come in and work alongside the F2HC when appropriate to do this research to help contribute to how they care for their patients. And that will allow us to develop and disseminate interventions that are going to address disparities, whether that's colorectal cancer screening, cancer care, or any other of the disparities that we see in health and healthcare. So in summary, I hope that you all have gained for this presentation that colorectal cancer is common, but screening is important, however underutilized. There are disparities that exist throughout the colorectal cancer care continuum, from prevention to early detection to treatment and survivorship. And I know today we talked a lot about prevention and early detection, but we could equally spend an hour talking about disparities in treatment and survivorship. There are many barriers to screening, and especially among Black patients and underrepresented groups, there are unique barriers that make it difficult for us to increase screening rates. Addressing disparities requires us to develop and disseminate evidence-based and multi-level interventions in diverse patient settings. So again, getting that we want evidence for these interventions, we want them to be multi-level, addressing patient, provider, system, and policy concerns, and also doing the research in the right place and addressing the community where they live and where they see providers. I want to thank you very much for your time and your attention today. I hope that this has been a helpful conversation, and I wish you all well as we continue to deal with the COVID-19 pandemic. Thank you very much.
Thank you, Dr. May, for a wonderful talk. That was inspiring and instructive, and you've given us lots of ideas about how we can proceed if we wish to follow along some of the trails that you've blazed for us. I would also like to thank Greg White and his family and all of the CSTAHR community members who are doing so much to teach our medical students and help them be the doctors that our communities need and want. Thank you to the CSTAHR students who particularly organized this extraordinary lecture. That's Amelia Davis, Mike Levy, Nikki Block, and Meta Godavalli. Thank you too to all of the CSTAHR community members, some of whom are in attendance, and many more of whom are laboring away in the vineyard of our communities, trying to help us deal with this problem of racism and bias. I would especially like to thank Greg's family, who are also with us today. We're honored to have you. With that, I would like to close our first annual Greg White Lectureship. Thank you so much for your attention.